So we have two presenters. First, we have Abriana Perez, or Aubrey. Aubrey is a dedicated public health professional and holds a Bachelor of Science degree in Health Sciences, Public Health from Northern Arizona University. Aubrey currently serves as the Maternal Health Program Manager, where she plays a vital role as the statewide coordinator for the Maternal Mortality Review Committee. Aubrey actively contributes to the field of maternal health by sharing Maternal Mortality Review Committee findings and partnering with stakeholders on prevention initiatives. Our second presenter is going to be, or is Kiran Leilani, infant and child health epidemiologist. Kiran holds a master's in public health from Rollins School of Public Health at Emory University in global epidemiology. Kiran currently oversees data analysis for the Home Visitation Program, Neonatal Abstinence Syndrome Program, and the Child Fatality Review Program. At the end of the presentation, we will have time for some questions. And at this time, I'd like to welcome Aubrey and Kiran. Thank you.
Okay, thank you, Patricia. And good morning, everyone. I'm Aubrey Perez. I am a program manager here at ADHS, and I'll be starting us off before passing it over to Kiran. Before we begin, I want to take a moment to acknowledge the individual lives lost that are represented in this data and the countless lives impacted by these tragedies. They are each a tragedy. Thank you, Felicia, for your opening words. I invite us all to reflect once more, to ground ourselves into the present moment and get into the receptive mode for the information you'll be hearing throughout this presentation and the others to follow. Please consider strategies to take action within your personal and professional power to improve maternal and infant health outcomes in Arizona. We have no conflicts of interest to disclose. Please note that the data I'll be sharing is preliminary, so I ask that you not take pictures of the slides. For our learning objectives for this presentation, I'll be providing an overview of the maternal mortality and child fatality review programs, share the latest data related to maternal and infant health outcomes in Arizona, share recommendations that, if implemented, would prevent maternal and infant mortality and improve health outcomes, and lastly, share opportunities to get involved. Before we dive in, it may be helpful for visual learners like myself to look at the context of these death reviews on a timeline. Maternal Mortality Review, or MMR, in Arizona includes those who passed away during or within 1 year of pregnancy within the ages of 10 to 60 years old. Child Fatality Review, or CFR, in Arizona, some states refer to it as CDR, for Child Death Review, includes children with a live birth who pass away before their 18th birthday. Sudden unexpected infant death, or SUID, includes infants who pass away before their first birthday without a well-defined cause. Fetal and Infant Mortality Review, or FEMUR, includes stillbirths and infants who pass away before their first birthday from any cause. Arizona does not currently have a FEMUR, but stay tuned for the final session on day 2 of the summit regarding the Fetal and Infant Mortality Action Plan. This visual shows us how there may be overlap between the different fatality review programs. Currently, CFR and SUID cases are reviewed closer to real time than MMR cases. Fortunately, these programs are housed within the same office, so we're able to collaborate if we share a particular case to ensure our Maternal Mortality Review Committee is informed of the decisions and recommendations made by the other review teams. Now I will provide an overview of the Maternal Mortality Review Program. So a good place to start when considering maternal mortality and morbidity is with this pyramid you see here that demonstrates the spectrum of potential maternal health outcomes during pregnancy and soon after pregnancy. The base of the pyramid represents the most common scenario of uncomplicated pregnancies. As we go up the pyramid, we see the less common but more severe scenarios of maternal morbidity, severe maternal morbidity, maternal near miss, and maternal mortality. Within the Bureau of Assessment and Evaluation at ADHS, we pay special attention to the top 3 scenarios in order to better understand and improve maternal health outcomes in Arizona. Cases of maternal mortality receive individual level case reviews, while cases of severe maternal morbidity and maternal near miss receive high-level analysis. Today's focus is on the tragic scenario of maternal mortality, or when an individual passes away from any cause within 1 year of pregnancy, regardless of the outcome, duration, or site of the pregnancy. Leslie de Rosset already gave us some national context, but to reiterate, pregnancy-related maternal mortality in the US has been increasing, and we're the only developed nation in the world to be seeing these increasing poor outcomes. We know that there are many factors that impact maternal health outcomes. Oftentimes, the blame is quickly put on the healthcare sector, stating that access to maternal health care is limited in certain regions, quality of care varies by facility, and cost of care is a barrier for many families. These are all certainly factors that should be considered, but as this slide shows, there are many others to consider. We won't read through them all, but at a glance, we see social determinants of health like housing, transportation, living conditions, etc., are underlying factors that should always be considered. Then we see multi-level factors, including patients and families, providers and healthcare facilities, and the systems and communities in which they interact. Within each of these categories are more specific factors, all things that can impact maternal health before, during, and after pregnancy. So we know maternal mortality and morbidity is a multifactorial concern. By identifying as many of these factors as possible, we can begin to understand specific opportunities for intervention and work together towards solutions that will optimize maternal health care. The Maternal Mortality Review Committee, or MMRC, is a multidisciplinary team tasked with the individual level case reviews of maternal mortality in order to identify these contributing factors and produce recommendations that would prevent future deaths. The committee is administered by the Maternal Mortality Review Program, or MMRP, which was established in 2011 and was awarded funding in 2019. In Arizona, our program reviews the deaths of all Arizona residents ages 10 to 60 who died from any cause within a year of pregnancy. The MMRP identifies the individuals to be reviewed and requests all available information about them. This includes data sources like death certificates, birth or fetal death certificates, hospital discharge data, and medical and social records. The clinical nurse abstractors review the information and summarize it in a de-identified case narrative. The case narratives are brought to the committee on a monthly basis, so the following questions can be answered. Was the death pregnancy related? Meaning, would she have died if she had not been pregnant, or did she just happen to pass away within the year of pregnancy? What was the underlying cause of death? Death certificates almost always state an immediate cause of death, but they rarely provide information about other things that may have led to the death. For example, if the death was a drug overdose, the death certificate would not include critical detail about the individual's mental health conditions, childhood trauma, or experience with intimate partner violence. It is important for us to capture all of these things that may have influenced her path that led to a drug overdose. Capturing this level of detail is only possible through these individual case reviews. The next question we aim to answer is, was the death preventable? And if so, what are the contributing factors to the death? And finally, what recommendations could the MMRC make that would help prevent these types of deaths in the future? To clarify the terms I'll be using on pregnancy relatedness, they are best described by taking a look at this tree. All of the leaves on the tree represent a pregnancy-associated death. They are associated to the death by time, because the individuals were all pregnant within 1 year prior to their passing. The pink leaves on the tree represent pregnancy-related deaths, or those individuals who would not have died had they not been pregnant. That leaves the blue leaves, which are pregnancy-associated but not related deaths, because of the cause of their death was not related to their pregnancy. For example, deaths as a result of a motor vehicle collision. Here is a brief status update of the program's current progress. The MMRC completed the review of 2020 cases and moved on to the review of 2021 cases earlier this month. For 2022 cases, there are changes to the process to help us standardize and streamline case identification with the help of the CDC NAPCS initiative. The MMRP continues to explore options to streamline the review process in an effort to move toward more real-time data. But today I will be going over preliminary maternal mortality data for Arizona for 2018 to 2019. As of today, we do have an infographic available for you to review, and a finalized data brief with more information will be available in the coming months. We'll begin with taking a look at pregnancy relatedness among deaths that occurred 2016 to 2019. In 2016, of the 75 pregnancy-associated deaths, 18 were pregnancy-related. In 2017, of the 59 pregnancy-associated deaths, 13 were pregnancy-related. As we move to 2018 and 2019, please note that per CDC guidelines, the age criteria expanded from 15 to 49 to 10 to 60. So in 2018, of the 69 pregnancy-associated deaths, 15 were pregnancy-related. In 2019, of the 80 pregnancy-associated deaths, 28 were pregnancy-related. Because of the relatively small case count over a one-year period, the data is more meaningful when we combine them in a two-year period and show the mortality ratio per 100,000 live births. Starting with the bottom trends in the purple, the pregnancy-related ratios, data from 2016 to 2017 show that for every 100,000 live births, there were approximately 18 maternal deaths. The 2018 to 2019 data shows a slight increase, where for every 100,000 live births in Arizona, there were 26 maternal deaths. Moving upwards on this visual in orange, we see the pregnancy-associated mortality ratios. 2016 to 2017 shows a ratio of 79 per 100,000 live births, and we were seeing an increase in 2018 to 2019 of about 91 pregnancy-associated deaths for every 100,000 live births. While the expanded age criteria I mentioned on the previous slide accounts for some of the additional cases we reviewed, we still know there is an overall increase between these two time periods. And we are seeing this increasing trend at the national level through the National Center for Health Statistics. Here we have the breakdown on pregnancy relatedness for the combined data set of 2018 to 2019. Of the 149 cases reviewed, 43 or 29% were determined to be pregnancy related. 72 or 48% were pregnancy associated but not related. For 34 or 23%, the MMRC was unable to determine relatedness because the committee felt we were lacking pertinent information to be able to rule out pregnancy relatedness. For the next couple of slides, we'll be looking at the percent of pregnancy-associated deaths compared to the percent of live births in the same time period, 2018 to 2019. Here we have the maternal age at time of death in the lighter shade compared to the maternal age at time of live births in the darker shade. Generally speaking, advanced maternal age tends to be associated with maternal mortality. However, most studies are considering pregnancy-related deaths as to pregnancy-associated deaths, as shown here. At a glance, we see that 88% of pregnancy-associated deaths occurred between the ages of 20 and 39. By comparing these two data sources, we can see disparities where the pregnancy-associated deaths exceeds that of the percent of live births for that age group. This is the case for ages 30 to 39, where 43% of pregnancy-associated deaths, despite accounting for about 39% of live births, and 40 to 49, about 5% of pregnancy-associated deaths, despite accounting for about 3% of live births. In 10 to 19, about 7% of pregnancy-associated deaths, despite accounting for about 6% of live births. Here is a look at the data by race and ethnicity. As a reminder, the pregnancy-associated deaths are represented by the lighter shade, and the live births are represented by the darker shade. If there were no disparities, the proportion of live births per racial ethnic group would equal the proportion of maternal deaths for each racial ethnic group. Unfortunately, this is not the case for two populations in Arizona, and that is for American Indian or Alaska Native, accounting for almost 15% of the deaths, and Black or African American, accounting for almost 11% of the deaths, despite them both accounting for just under 6% of the live births in Arizona. Per CDC, at the national level, we are generally seeing higher rates among both of these racial ethnic groups, although it is difficult to cross-compare because of differences with racial ethnic makeup, how racial ethnic data is grouped together, and overall data availability for the time period. Here is a look at the data when we piece it out into urban and rural areas for maternal residents. The majority of the deaths, almost 78%, occurred in urban areas. Where we see the health disparity is in rural areas, where about 17% of the deaths occurred, despite these areas accounting for just under 13% of the live births in Arizona. Studies by Tross and Harrington found a similar trend, although they specifically looked at pregnancy-related deaths. But here it was noted, although the reasons for the higher rates of adverse maternal outcomes in rural areas are likely multifactorial, substantial declines in hospital-based obstetric services between 2014 and 2018 in rural counties highlight the importance of policy efforts to ensure access to high quality and high acuity care. Previous work has also demonstrated rural-urban differences in individual cardiovascular health factors that may contribute to adverse maternal outcomes such as obesity, diabetes, and hypertension, as well as adverse pregnancy outcomes such as hypertensive disorders of pregnancy. Another important piece to mention here is a report by the March of Dimes that points out that of the 15 counties in Arizona, 3 have low access to maternal care, and 1 is considered a maternity care desert with no access to maternal care. Stay tuned for the sessions after this one to hear from some policy experts. This is a bit of a deeper dive into the data by geographic region. We see the majority, about 64% of these deaths, occurred in the most populated region of our state. Where we see disparities are in the northern and western regions of the state, where the percent of maternal deaths is more than the percent of live births in those areas. Again, we can consider the factors that were just mentioned as it relates to maternal residents. This is the last slide in regards to demographics. So this one pertains to education status. For 39% of pregnancy-associated deaths, there was documentation of having a high school diploma or GED, which exceeds the percent of live births with the same education at 27%. For individuals without a diploma, these accounted for 22% of pregnancy-associated deaths, despite them accounting for 13% of live births. So we do see a similar trend worldwide, which is why social determinants of health are a critical factor when assessing maternal mortality. The MMRC determined that of all the 149 cases reviewed, about 23% were pregnant at the time of death. The MMRC determined that 94% of these were preventable. About 18% were pregnant within 42 days of death, of which 89% were determined to be preventable. The majority of the deaths, almost 60%, occurred within 43 days to 1 year after the end of pregnancy. Of these, it was determined that 89% were preventable. Now, the MMRC also considers among those deaths that were determined to be preventable, if there were one or more feasible changes that could have occurred at the patient, provider, facility, system, or community level, what would have been the chance to alter the outcome? The MMRC determined that about 40% had a good chance of preventing the death, and for 53%, there was at least some chance of preventing the death. The remaining 7.4% include no chance, unable to determine, or missing data. Individual counts of these were less than 6. There are definitely things we can all be doing to reduce these preventable maternal deaths and ultimately improve health outcomes for individuals and their families. For the primary underlying cause of death for the 43 pregnancy-related deaths, almost 33% were attributed to mental health conditions, about 16% to hemorrhage, and about 16% to infection. The remaining less than 12% were attributed to the causes listed here. 10 of the 43 had a secondary underlying cause. There was some overlap with mental health conditions as a primary and secondary cause in the case of, for example, depression and substance use disorder. Similar trends were seen in a CDC analysis of 36 states with MMRCs, where mental health was the top underlying cause at 22.7%, followed by hemorrhage at 13.7%. The MMRC also determines if the following factors may have contributed to the death on a scale of yes, probably, no, or unknown. Substance use disorder was a contributing factor in 48% of pregnancy-associated deaths, with 42% being pregnancy-related. Mental health conditions was a contributing factor in 38% of pregnancy-associated deaths, with 40% being pregnancy-related. Obesity was a contributing factor for 12% of pregnancy-associated deaths, with 21% being pregnancy-related. If you're interested in a deeper dive into mental health and substance use related deaths, I encourage you to refer to our topical report that was released in 2022. With the information available, the MMRC also determines if the death was a homicide or a suicide, regardless of what is listed on the death certificate. This question is also on a scale of yes, probably, no, or unknown. About 12% of the deaths were yes or probably a homicide. Almost 9% of pregnancy-associated deaths were yes or probably a suicide, and 14% were pregnancy-related. So we're finished taking a look at the numbers, and now we will talk a little bit about the recommendations for improving maternal health outcomes. So here's a list of recommendations that we know are being implemented. I invite you to check out our website to explore this list in more detail. I'll just point out a couple here from the most recent developments. So effective April 1st of this year, Arizona extended postpartum coverage from 60 days to 12 months. And effective June 1st of this year, the Arizona Perinatal Psychiatry Access Line, or APAL, was established to provide real-time provider consultation. And you'll be hearing more about these initiatives throughout the summit. The recommendations listed on the next couple of slides are a subset of those included in our 2020 report. Please consider what you can be doing within your personal and professional power to improve maternal health outcomes. Patients and families can become active participants to advocate for their individual needs and adhere to recommendations for timely and appropriate care. Providers can communicate health information in a way their patients will understand and advance their skills in obstetrical emergencies. Facilities can implement patient safety bundles, improve continuity of care through patient-centered or family care models, and adopt a health equity framework. Communities can develop and provide outreach and education, ensure access to services that support social determinants of health, and provide peer support. Regulatory or state policy can expand the diversity of the maternal health workforce, establish requirements for continuing education, and identify ways to achieve a universal medical record. Payers can ensure appropriate reimbursement for patient-centered family care, peer support, behavioral and mental health models of care. Adopt maternity care incentive plans, adopt American Indian medical home models, provide access to the full range of reproductive resources and other resources that address social determinants of health, and recognize perinatal behavioral health specialists as a contracted medical specialty. First responders and law enforcement can dispatch behavioral health providers on calls, establish harm reduction programs and protocols, and establish supportive environments for those experiencing domestic or intimate partner violence. Some of the other systems changes include becoming a trauma-informed state, expanding access to telehealth services, and reducing stigma of maternal mental health and substance use disorders. And as was mentioned, keep an eye out for our data brief with updated recommendations derived from the 2018 to 2019 reviews. And if you're interested in participating in the Maternal Mortality Review Committee to review the causes of maternal mortality and inform prevention recommendations, there are multiple ways to get involved. I invite you to indicate your interest in the summit evaluation so I can reach out to you with an application link. The application will ask about your personal and professional experience in maternal health. MMRC leadership will review your application and you'll be notified of their decision by October 1st. The virtual orientation will be in October, and the first meeting will be in person on November 6th. We usually meet monthly via Zoom, but twice a year after recruitment, we meet in person to connect and learn together. If you represent a professional discipline or organization, your membership is voluntary. Now, if you're a member of the public and you personally or through a close family member experienced a maternal health issue, and you are in a place to share your perspective to inform prevention recommendations, you may be eligible to receive compensation as an advisor to the MMRC. If you're interested in this role, please reach out to me directly at my email provided. Just provide your name and indicate your interest in the role, and I'll reach out to schedule a call to provide more details. If you have any questions specific to the MMRC, please don't hesitate to reach out. My email will also be provided at the end of the presentation. So here are the list of resources. Thank you so much for your time. And I'll now pass it to Kieran to discuss the Child Fatality Review Program.
Thank you. So, as mentioned before, my name is Kieran Lalani, and I am the Infant and Child Health Epidemiologist for the Arizona Department of Health Services, and I'm here today to talk about the Child Fatality Review Program. So, who are we? The Arizona Child Fatality Review Program, it is a state-mandated program established in 1993 with the aim of reviewing all child deaths aged 17 and younger in Arizona and identifying preventable factors and opportunities for prevention. We work with people at the state and local levels from multiple disciplinaries to share and discuss comprehensive information on the circumstances leading to the death of a child and the response to that death. These reviews can lead to action to prevent other deaths locally, at the state level, and even nationally. Currently, we have 10 local CFR teams all across Arizona that complete 100% of our death reviews. Second level reviews of sudden unexpected infant deaths and abuse neglect deaths are done at the state level by subcommittees of the state team. Next. So this is a map of our local CFR teams and where they're all located. As you can see, some of the counties have the same colors, and that means that they are reviewed by the same team. Next. So as stated in our mandate, our local team members include a wide variety of people from county medical examiners to the Department of Child Safety, pediatricians, person from the local law enforcement agency, and even parents. And with all of these members, the 10 local teams complete 100% of our death reviews and provide recommendations for prevention at the community level. Children are not supposed to die. The death of a child is a great loss to family, to friends, communities, and often represent unjust sufferings and unfulfilled promises. Understanding the circumstances causing a child's death is one way to make sense of this tragedy and may help to prevent other deaths of other children. So, using what is reviewed at the local level, the state level develops an annual report along with infographics and other county level reports while providing oversight to the local CFR teams. This annual report provides a comprehensive review of fatalities occurring in Arizona among children. And this report's demographic and prevention information is used to help broadly inform public health initiatives and the community at large. Next. So on November 15, 2022, we published our 29th annual report that contains information about the Arizona child fatality from 2021. Next slide. So in 2021, there were a total of 863 deaths in Arizona among children 17 years and younger. Substance use was involved in 1 out of every 5 child fatalities, and boys were victims of 79% of firearm injury deaths. And 95% of sudden unexpected infant deaths occurred in an unsafe sleep environment. Next slide. So when looking at the leading causes of death among age groups, we can see that prematurity was the leading cause of death for infants 0 to 27 days, while suffocation was the leading cause of death among infants 28 days to less than 1 year of age. Drowning was the leading cause of death in children aged 1 to 4 years. Motor vehicle crashes was the leading cause of death among children 5 to 14 years, while firearm injuries was the leading cause of death among 15 to 17 years of age. And in that last row, it shows among all the deaths, and we can see that prematurity was the #1 leading cause of death in Arizona in 2021. Next slide. So looking more closely at infant deaths, in 2021, there were 428 infant deaths, which was 50% of all Arizona deaths for this year. Next. Arizona infant mortality rate has been fluctuating since 2012. So since 2020, Arizona's infant mortality rate has increased 12.1% from 4.9 deaths per 1,000 live births to 5.5 deaths per 1,000 live births. The Arizona infant mortality rate has consistently been lower than the US rate. And right now we're working on our 2022 data, so hopefully that stays the same for this year. Next. The majority of infant deaths were among males at 53%, followed by females at 47%. 69% of infant deaths were among neonatal infants, which is less than 28 days, and 31% were among post-neonatal infants, 28 days to 1 year of age. Black and American Indian infants have consistently had higher rates of infant mortality, and in 2021, this was the same as well. For Black and American Indians, they were 14 and 5.4 deaths per 1,000 live births, respectively. And Hispanics and white infants were 5.9 and 4.0 deaths per 1,000 live births. All infant mortality rates, except for American Indians and white infants, increased, with the highest rate increase for Black infants at 10.3% from 2020 to 2021. Next. So to look at the disparities in race and ethnicities, we like to show a comparison of what the population in Arizona looks like by looking at the percentage of live births compared to the percentage of infant deaths. So as we can see here, Black infants were disproportionately affected, being that they made 16% of infant deaths, but only made up 6% of the live births. The majority of infant deaths were among Hispanics and white infants. Next. So a big problem recently has been substance-exposed newborns. Substance-exposed newborns, or SEN, is an identification assigned to an infant if they were delivered drug-exposed as determined by the childbearing parent's history, clinical presentation of the newborn, and/or lab testing. In 2021, 12% of infant deaths, or 49 cases, were classified as SEN infant deaths. 57% of these cases were classified as males, and 43% were classified as females. Of the 49 SEN infant deaths, marijuana was the most common substance used in 32 cases. And this is followed by methamphetamines at 16 and opioids at 12. And as a note, there may be more than one substance used in each of these SEN cases. So of the 49 SEN deaths, prematurity was the leading cause affecting 25 infants. But what exactly is prematurity? Next, please. So prematurity deaths, these are deaths due to a premature birth, which is less than 37 weeks gestation, of an infant with no underlying medical conditions that would have resulted in the death of the child. In 2021, 48% of infant deaths, or 206 cases, were classified as premature deaths. 57% of these cases were classified as males, and 43% were classified as females. Black and Hispanic infants made up 19 and 47% of premature deaths, respectively, but only comprised of 6% and 40% of the premature births. The majority of premature deaths were among Hispanic infants at that 47%. While there are numerous risk factors that can contribute to premature deaths, the most commonly identified risk factor was poverty at 50% and premature rupture of the membranes at 40%. And as a note, there can be more than one factor identified in each of the deaths. Another huge issue among infants is sudden unexpected infant death, or SUIDs. So SUIDs is a death of a healthy infant who is not initially found to have any underlying medical condition that would have caused their death. Most SUIDs are due to suffocation and unsafe sleep environments, but not all SUIDs are sleep-related. In 2021, 15% of infant deaths, or 65 cases, were classified as SUIDs. 58% of these cases were classified as females, and 42% were classified as males. Arizona's SUID rate has actually increased 23.1% from 0.65 deaths per 1,000 live births in 2020 to 0.8 deaths per 1,000 live births in 2021, as you can see in the darkest row. Additionally, Arizona's unsafe sleep environment mortality rate and suffocation mortality rate have increased since 2012. As we can see here, Black infants were disproportionately affected, making up 15% of the deaths and only 6% of the total population. The majority of SUIDs were among white and Hispanic infants. While there are numerous risk factors that can contribute to SUIDs, the leading risk factor was unsafe sleep environment, followed by the presence of objects in sleep environments at 95%. As a note, more than one risk factor may have been identified for each of these deaths. So in response to the data in this report, the State Child Fatality Review Team makes evidence-based recommendations to help prevent infant and child fatalities within the state. For the sake of this presentation, we're only including those recommendations for the issues that we discussed. Next slide, please. So in relation to the SCN cases seen throughout the state, some prevention recommendations to help minimize substance use related deaths include training professionals in trauma-informed care to better address ACEs, improving access to personalized substance use disorder treatment plans, expanding access to services for those experiencing unstable housing and homelessness, and increasing the availability of naloxone. Next. With prematurity being the most common cause of death among neonates, some prevention recommendations include avoiding substances such as drugs or alcohol during pregnancy, encouraging regular prenatal care, increasing the availability of affordable health insurance, and increasing the availability of home visiting programs. For SUID cases, prevention recommendations include educating parents on safe sleep environments and increasing home visiting programs for infants following birth for up to 1 year of age. So the Arizona Maternal Mortality Review Committee and the Child Fatality Review Program work diligently to put out recommendations to improve maternal and infant health outcomes. We don't have the time to walk through all of the report findings or recommendations today, but know that the agenda for this summit was built with this information in mind. If you would like to review the information in more detail, please go to our website or use the QR code to review the following reports and infographics. Thank you.
Thank you, Aubrey, and thank you, Kieran. We've received several questions through the chat. And what I'd like to do, if it's okay with you guys, is just kind of take a maternal mortality review question and then a child fatality question so that we can get through the majority of the questions in that way. And before we get to the questions, I just want to recognize that we got a couple of comments indicating interest for access to the slide set. And the response is just to let everyone know that all the slide decks provided by any of the presenters today and tomorrow will be sent out in about 7 to 10 days, right after the close of the evaluation link. So please be sure to complete the evaluation for the summit to receive these slide decks and certificates of attendance or CEUs. Aubrey, you did get positive feedback. Someone in the audience really liked your slide on factors impacting maternal mortality and morbidity. The comment was, this is a great one. So I'm sure that they're anxious to get your slide deck as well. One of the questions that came in, and Martine did provide this response, but I want to recognize the question. Are you able to overlay racial ethnic disparities on top of rural/urban differences? Are the disparities within the Black community more prevalent in rural or urban areas? And that question was in response to maternal mortality. Martine's response, I'm sorry, I don't see that here, but we did provide that response. Aubrey, this next question is for you. I wondered if you might be able to talk a little bit about just provide more information if individuals are interested or contemplating becoming maternal mortality review committee members. Can you talk a little bit about the support that an individual would get to assist them in that role and onboarding? I'm just hoping that we take this opportunity to kind of expand your the diversity of your team members as well.
Definitely, thank you. So I mentioned the application process and kind of the timeline, and then what to expect during the onboarding is a virtual kind of onboarding orientation where we get you familiar with the data, the most recent data we have, and then an orientation to the review process. And then to provide support on this work that can be very challenging. We kind of structure our meetings where before the beginning of our meeting, we have professional development to share learning among the committee. And then before and after we have our case reviews, we have a moment of silence to honor those that we are reviewing. And halfway through the meeting, we have a 5-minute break to kind of step away before we get back into it. And then at the end of the meeting, we have the opportunity to debrief and talk about anything that came up. Also for our advisors, that advisor role that I mentioned, we have an additional check-in meeting after, it's the Friday after our review meeting. So we have an opportunity to collect any, to debrief and collect any additional information we might have missed during the review meeting. And then as always, ADHS staff is available for one-on-one support as needed. And one other piece is we have 2 in-person meetings. And so those expand, we have a little bit more time to incorporate self-care, a meditation perhaps, and just a time to connect and support one another through this work.
Thank you. Thank you, Aubrey. Kieran, we do have a couple of questions that came in. Just want to recognize that they were responded to by Martine. The question was, does firearm injury include suicide attempts? And Martine's response was, yes, it does. Firearm injury deaths include all manners of death, accidental, homicidal, suicide, and undetermined. Is there anything that you would like to add to that, Kieran?
No, the only thing I would like to add is that if you are more interested in that specific topic, you can go to our annual report and we have it all laid out in detail exactly what it means. Just for the sake of this presentation, we didn't really go into it, but if you have any questions, I would direct you towards the annual report. And then if you have additional questions, feel free to reach out to me and I'm here to help.
Thank you, Kieran. This is a question, Aubrey, that came up during your presentation, and Martine did provide a response, but I want to make sure the audience is able to hear it. The question is there a state or national effort bill that you know of to address the lack of OB, midwife, etc. services in rural areas? And Martine's response was, we know of some initiatives nationwide to address maternity care deserts. For example, the Human Resources Services Administration established a new federal shortage designation called Maternity Care Target Areas, MCTAs. The department uses these shortage designations for strategic planning and allocating resources, and that link was provided in the chat box. Martine goes on to say that tomorrow's presentation on the Fetal Infant Mortality Action Plan will briefly touch on statewide initiatives that are planned for and around this topic. Next question, Kieran, that we have here is in regards to substance exposure evaluation, what is being done to eliminate bias, especially racial bias in evaluation?
So I know this year we have decided to focus a little bit more on it, knowing that what the numbers were from 2021. So personally, I haven't looked into it yet. I'm not at that stage yet in my discovery of SEN. But I know that this year's report reflecting on the 2022 data will have a lot more information about the recommendations, about the different programs that are happening in Arizona specifically for that. So we're going to have a whole section in our report dedicated just to SEN and talking more about that.
Okay, thank you. Aubrey, this question is for you. Is it possible to see data related to our own healthcare system or at least region? If so, where is that available?
Great question. I would invite others to help offer these resources, and I'll definitely follow up to the question with some more information. So thank you.
Okay, thanks, Aubrey. Kieran, we have another question here. It says, the question states, did you say you are looking for more folks for CFR? I have someone I would like to nominate.
I don't see why not, honestly. So if you want, you can just reach out to me and then I can see what we can do about it. And then just we'll let you know.
Okay. These next few are coming in. First, a comment from Dr. Burkle. She states, we just got a grant to look at increasing access to doulas. If anyone has input, please reach out to me or Jenny Beaver. Dr. Burkle, I recommend that you please put your contact information in the chat. That way others might be able to reach out to you. Another comment that came in related to maternal mortality, and then I'll get to a question for you, Aubrey. Comment from Marina Farrell. She says that she will be hosting a meeting at the end of this month to discuss Medicaid access for midwives. If anyone is interested, she does provide her contact information. It's marina@indigenousbirth.com. The dates are August 30th and 31st, and this is specific to Arizona and midwifery access. It's in all settings. Thank you, Marina, for that information. Aubrey, this question reads, do you know if Indian Health Services will cover doula services and midwifery care in the near future, since there is a great disparity according to the numbers that are being presented?
Great question. I know that there is work being done in this space, but I don't feel that I am the best person to address this question. We do have members on the committee with Indian Health Services, so I'd be happy to route this question and get back to you. In regards to the previous question about data related to your own healthcare system, our epidemiologist, Glenda Ramirez, has offered to offer some information on this.
Hi, yes, thank you, Aubrey. Can you hear me okay?
Yes.
Great. Okay, great. Thank you. Yeah, I just wanted to mention that there are potential ways that you can have access to data related to your own specific healthcare system or region. It just depends if we have some reports available online with that information. So if you take a look at some of the reports that we have available and you're not finding data specifically to what you're looking for, there should be a link available on our website where you can ask for specific data that relates to something that you're interested in. Since it would be a very specific data request, it might take some time to be able to pull that together for you, but depending on your needs and if we have that data available internally, we could potentially get you access to some of that information. Also, we do provide the Arizona Perinatal Trust, depending on your healthcare system. If you are certified, there are some community profiles that are made available on an annual basis to your to specific point of contacts within your hospital systems that have some maternal and infant data indicators available there. So that is one other source of data available to you all on an annual basis, depending on your hospital system and if you are certified through APT.
Thank you, Glenda. That's great. Appreciate you providing that piece of information. Another question that came in, Kieran, and there is a response, but I want to make sure that the audience gets to hear it. The question was curious that there isn't a clear, I'm going to read it as it's stated. Curious that there isn't a clear addressing of systemic racism as a leading cause of maternal and newborn morbidity mortality. Did I miss it? A separate slide that affirms this would be appreciated. Important to use the word so that it isn't about people of color. Thank you. That's from Marina. And the response is the mortality review programs do collect data on discrimination and specifies at what level. Our upcoming report will have more information on this. This point is brought up during each of our case reviews. And it looks like that is the bulk of the questions that I see on our document here. Are there any other questions that I don't have in front of me that anyone would like to ask? I'll ask our team that's monitoring the chat. Do we see anything else that's coming in for question or comment? Okay, I don't, oh, nothing else is coming in. Thank you so much, Glenda. Appreciate you responding to that question. Well, thank you so much, Aubrey and Kieran. Appreciate the information that you all provided and your attention to detail and the use of the data and how that's continuing to guide your work. Thank you so much.